Welcome to Docs on Call, brought to you by Methodist Medical Center, with your host, Gina Morse.
Good evening and welcome to Docs on Call. Tonight's topic, when heartburn is more than an annoying burning pain. Nearly 1 in 10 Americans experiences the symptoms of heartburn at least once a week. In most cases, those symptoms can be controlled. There are also alarm symptoms that could signal more serious conditions that should not be ignored. Heartburn, GERD, and Barrett's esophagus are some of the topics on this week's Docs on Call, brought to you by Methodist Medical Center. Dr. Omar Kokar of Illinois Gastroenterology Institute and Dr. Ryan Walsh of Methodist Medical Group Family Medicine at Allen Road will answer questions and provide more specific information on this, the symptoms, causes, and treatments. So call in now, talk to our experts by dialing 698-3742. That's 698-3742. Let's meet our aforementioned guests. They are Dr. Omar Kokar of Illinois Gastroenterology Institute and Dr. Ryan Walsh of Methodist Medical Group Family Medicine at Allen Road. And again, they're answering your questions and providing more specific information for you on these treatments. Sitting closest to me is Dr. Kokar, a 2002 graduate of Rawalpindi. Did I say that correctly?
You did.
Thank you. Medical school. No, that's not around here, folks. He can tell you more about it, though. He is board certified in internal medicine with a subspecialty in gastroenterology, and among his clinical interests is GERD. And to his left is family medicine physician Ryan Walsh. Dr. Walsh is a graduate of the University of Illinois College of Medicine at Peoria. He provides primary health care medical services to patients of all ages, from preventive care to the management of chronic illnesses like Barrett's esophagus. Let's talk a little bit more about that. Thank you to you both for lending your expertise this evening. We'll begin with that subject of Barrett's. Explain, if you would, a little bit about this condition, how it's different than, say, simple heartburn. And while you do that, let's go ahead and show the viewers at home some video. This is the Methodist ablation therapy for Barrett's esophagus. Tell us about it, doctor.
Well, Barrett's esophagus is a condition that occurs as a result of chronic reflux. If reflux occurs for more than 5 or 10 years, the surface of the lower part of the esophagus changes in order to protect itself. And as a part of that change, that change is called Barrett's esophagus. The problem, however, is that not everyone will stop at Barrett's esophagus. In 250 people will actually progress to esophageal cancer. And so that we now know that Barrett's esophagus is in fact a pre-malignant condition that should be aggressively treated medically or with other interventions.
The reason we were saying earlier that you should not ignore those symptoms, kind of a warning sign of perhaps worse things to come.
Correct. And other alarm features that physicians refer to in terms of heartburn are weight loss, black stools, inability to swallow, difficulty swallowing, painful swallowing. If any of these are present, they're a harbinger of potentially something more serious.
And as we're looking at this video, too, this ablation procedure, what can you do to provide relief?
Well, from a patient's perspective, this is very similar to undergoing an upper endoscopy. But what we do is attach an electrode to the end of the endoscope, and then with a foot pedal deliver energy to the area which is involved. This area then is like a scab, as if you burn yourself on a stove and you get a blister. And so what happens is that when that blister heals, the new skin comes on top, and the Barrett's mucosa is then eliminated.
All right, interesting. Well, we already have a caller, so thanks for that information. Let's hear what Kay has to say. Thanks for watching Docs on Call. What's your question, Kay?
Well, I have GERD, and quite often I will be awakened during the night with what I would say are symptoms of, it feels like you're having a heart attack. The pressure, the pain, it goes up the throat, up the neck. What is a person to do? Because you cannot run to the emergency room every time you have this reaction with the GERD.
Yeah, no
and
kidding.
how do you determine if it's GERD or if you're having a heart attack? Do you know what I say?
Okay, thanks for the question. Dr. Walsh, what do you think? What do you tell patients like Kay?
Yeah, I was going to say, Kay, the first thing that I would always toss out, and of course being a primary care physician, I would say, get in to see your primary care physician. But actually, of course, there are lots of different reasons that you can have chest pain of course, we always worry about, are you having cardiac type symptoms? And that's really something you need to let your doctor determine. But there is a set of symptoms from what's called esophageal spasm, and the esophagus is lined with smooth muscle, similar to many other parts of your body. And when that becomes irritated by chronic acid exposure, they can in fact spasm, causing chest pain like that. And for it to happen at night is more common in gastroesophageal reflux disease.
Because you're laying down?
That's exactly correct. So the force of essentially gravity and also the pressure of your body pressing down upon the stomach, making the gastric contents leak back, can cause that acid to come back and irritate the esophagus. But if you haven't been checked out by your primary care physician and you are having pain in the chest that does sound like a heart attack, make sure it's not a heart attack first.
Oh, absolutely.
And then treat it like it's GERD.
Does a simple thing like propping a few extra pillows at night when you sleep, those kind of measures
It's
help?
one of the first things we always suggest, and absolutely it helps. So you want to get at least between 10 and 15 degrees of tilt on the head of the bed. You can do that by placing a couple boards under the front side of the bed or a foam wedge underneath your mattress. Absolutely.
And how about the fact, Kay, as a woman, we know that the symptoms of heart attack in a woman versus a man can be different. And so some of those symptoms she was describing sounded very much like what a woman might experience when she's got that kind of heart issue. And as she said, she doesn't want to run to the emergency room, though, every time.
Sure. I would echo and reinforce what Dr. Walsh has said in this situation. If a patient especially has other risk factors for a heart attack, such as obesity, age, previous family history, etc., cardiac should be ruled out first. And if you've seen your primary care doctor and you've established that this is not cardiac, then it should be time for intervention. First of all, like Dr. Walsh said, lifestyle modifications, raising the head of the bed, not eating 3 or 4 hours before you go to bed, avoiding wearing tight-fitting clothes. These are all things that can cause reflux to occur from the stomach to the esophagus. And if these don't work, then we have a sequential manner that we use in terms of medications to prevent reflux from occurring.
And are medications commonly used nowadays?
I'd say it's probably one of the most common medications.
And we're not talking
we
about your
use.
typical antacid. There are quite a few medications now
Right.
to treat it.
There's now a family of medications called proton pump inhibitors, and these are more commonly known as Nexium, Protonix, Prilosec. And what these do is these suppress the pumps that make acid in the stomach. And by reducing the amount of acid in your stomach, thereby prevent the amount of reflux occurring and prevent symptoms from occurring.
All right, very good. Lionel had called in this question for us. He said, heartburn bad at night, causes vomiting, and he has to sleep, I think, sitting up. You say that that's not necessarily bad because that is at least providing some relief. But I'm sure that something so nagging that continues to give him that kind of problem, boy, I bet he's wishing that there's something more that he could do besides, propping a few extra pillows. Is there ever a chance when some of those medications that you were just discussing aren't enough?
Well, there are times. I think it's a multi-faceted approach. Lifestyle modifications, medications. In some instances, surgical correction can occur depending on the underlying condition of the patient. But for the most part, the PPIs are very effective at controlling acid reflux. Now, in this case, if he has vomiting, that's something that he should probably seek further medical attention for.
Go see Dr. Walsh or someone like him first, and let's really talk about that. And then you would probably refer him to someone like Dr. Kokar.
Certainly. And in patients that have severe reflux that do have vomiting, one of the things I often worry about is a condition called gastroparesis, where the stomach doesn't empty properly. So not only do you have a problem with the reflux of the contents back out of the stomach, but the stomach isn't emptying, so it exacerbates the problem, and eventually it can get bad enough to cause vomiting as well. And yes, actually, that would be one of my first calls would be to Dr. Kokar's office.
All right. Kalisa is on the line now. Thanks for watching Docs on Call. What's your question?
Well, I am on morphine and Norco, and that's for pseudotumor cerebri. and I get really nauseated. I've tried Zofran and I've tried Norco, and it has not worked. Is there an alternative that I could take for it?
Well, Lisa, we're sorry you're having to go through so much. Good question. I'm sure there are other people out there who are on some medications for other medical conditions that then have this side effect.
Right. And this actually ties into what Dr. Walsh had just talked about, gastroparesis. Narcotic medications are notorious for causing slowing of the stomach. And this could actually be a side effect of the medication she's taking. I think it'd be a good idea for her to come see the doctor and get the process worked up.
So are there potentially some alternatives, you think, after
the other medications?
Yes.
There are motility medications that we can use which help, if you will.
By motility?
Motility, I mean sort of jump-starting the stomach. Think of it as jumper cables for the stomach. They're medications that help increase the propulsion and the mixing function of the stomach. And if we can get the stomach to pump better, that'll help the acid flow in the right direction. That'll prevent it coming up into the esophagus.
All right. Kalisa, thanks again for that call. Phyllis had called in with this question, diagnosed with a hiatal hernia and has burning in the tongue area, and is wondering if this will be permanent. And because acid is coming back up there, Prilosec is helping, but will it get better? That's what Phyllis wants to know. Do some of those issues make sense?
Well, it depends on the duration of symptoms. I'd like to see how long she's had the symptoms, how long she's been on the medication, what dose of medication or Prilosec she's been on. And we can certainly increase it to a higher dose for a short period to see if that improves the symptoms. But generally, you'd expect it to resolve by now.
Okay. All right. Thanks for that question, Phyllis. Now let's go to a question from Lisa. Thanks for watching Docs on Call. What's on your mind?
Yes. I was just wondering, I heard that you're talking about heartburn. I have had my gallbladder just taken out in January because I thought I was having a heart attack then. And they said, no, it was gallstones. Now, after I've had my surgery, I still keep getting the heartburn or the chest pain in my really bad chest. And I get it in the morning, I can get it, and it will last for anywhere from an hour to 3 hours. And I just saw my regular physician. I've been taking Prilosec for quite a while, and I've been taking Allegro with it, and he put me on Singular, and I had an attack Saturday, and it lasted for it was Saturday morning, it lasted for 2 hours. So what can I do?
Guys, what kind of advice do you offer Lisa? Sounds like she's having a rough time of it, especially after already going through the surgery.
She brings up an interesting question, and that's a question of non-acid reflux. Generally, when we talk about reflux, for the most part, we're talking about acid. However, in certain cases, and having your gallbladder taken out is a major cause of this, you can get acid reflux with other things such as bile, gastric juice, and pancreatic juice. So that's one thing I would look into, that if her gallbladder has been removed and she still has reflux symptoms, Prilosec, even at a double dose or a higher dose, suppresses acid, but it's not suppressing what actually may be causing her symptoms.
Interesting. Okay.
So frequently when I have a patient that has that,
yes,
I'll end up referring them to a gastroenterologist who will be able to perform endoscopy and be able to note, is there bile acid reflux? Is there, where are we seeing the reflux from? And then use medication subsequently to be able to treat that and provide relief.
Well, not all medications are created equal because they're created for different problems, right?
Correct.
Even though we think that it's the same thing because it's causing us the same kind of pain, where it's coming from, what that pain generates from might be different. Okay. Kathy is on the line now. Let's hear what she has to say. Thanks for watching. What's your question?
My question would be, sometimes at night, it's either I've had heartburn or acid reflux that kind of wakes me in the night, but then the whole next day I'll have this burning sensation in my esophagus that seems to, it's not real painful, but just uncomfortable. And I've been trying to find ways of trying to relieve that, like to cool that sensation or numb that sensation. Is there any kind of meds over the counter that you can get that will help with that, or is it just what happens as consequence of having acid reflux or heartburn?
Thanks for the question, Kathy. Doctors, what do you think?
This is a great question. I think she's referring to, I'd like to know more about what's going on, but a lot of times when you have reflux during the night, what occurs is something called erosive esophagitis, which is inflammation of the lining of the esophagus. And that generally requires prescription therapy to cure. And that can be diagnosed with upper endoscopy.
Okay. All right, Kathy, we hope that helped a little bit. And to you, our viewers at home, let's go ahead and take a quick break. When we return, our experts are taking more of your questions about GERD, heartburn relief, and prevention. This is Docs on Call. We'll be right back. Welcome back. Our topic tonight is heartburn. From the occasional burning to the more serious Barrett's esophagus, we're asking our experts from Methodist Medical Center about how to cope and even prevent the pain. Just dial 698-3742. That's 698-3742. Let's get right to another question. This one comes to us from Patricia. Thanks for watching. What's on your mind? Patricia, are you there?
Yes, I am.
All right. What's going on with you?
Well, I've had this for quite a few years, and what happens is I vomit every time.
So you've got some acid reflux that's causing vomiting?
Well, that's what they're telling me, and I think it's what it is acid reflux, because it burns. And I vomit about once a month, and I just did it the day before yesterday. And what happens is I go to the bathroom, and then saliva starts just like water coming out of my mouth, and that's what causes me to start vomiting.
Do you have symptoms before that?
Pardon?
Do you have any symptoms before that?
No. I just get that saliva, and it just keeps pouring out, and then I try to keep from vomiting, but it don't let you keep from vomiting. You just keep vomiting and vomiting. And it doesn't seem like I can get any answers. I go to the doctor, I go to my specialist, and they tell me it is acid reflux. Yes, but I've been doing this over 4 years.
Have they given you or prescribed any medication for you?
Yes, I take the medication. You take one a day, and it's supposed to work, and but it's not working. None of the medicine they give me is not working at all.
Yeah, it doesn't sound like it. Doctors, what do you think? Is it maybe the medication? Is it the dosage, which she perhaps needs to take 2 a day? What could her problems be?
It could be all of the above. In her situation, again, given the duration of her symptoms, along with the vomiting, I think it's important to do an upper endoscopy to make sure there's nothing else. She may have a stricture or a narrowing of her esophagus that may be preventing food from going down or allowing her saliva to pool. And so there's other reasons that she may have that need to be excluded with direct visualization of her esophagus and stomach.
Okay. Let's hear from Dave. He's on the line now. Dave, thanks for calling into Docs on Call. What's on your mind?
Yes, I just had a question. I know for the last 5, 6 years, I have to about every other year, year and a half, I have to get my esophagus enlarged. And what my problem is when I'm laying in bed sleeping, I get so much heartburn in my middle of my chest. I wake up and I get a glass of milk and it takes care of it. Well, then the next morning when I'm eating or drinking or whatever, it seems like it's regurgitating my throat. And when I went to see my doctor, I have the scope go down there and stretches my esophagus.
Have you had that done multiple times?
Yes, about 5 times in the last 10 years.
Okay. And do you have to get it done more often as time goes by?
Yeah. And they do a biopsy where they look for, and everything comes back negative, thank God.
Dr. Walsh, is this something that you hear about from your patients often, as far as someone who has this ongoing issue and maybe they've had to get their esophagus stretched? And either of you might want to describe what what that means and why somebody would need to do that. But where they have to kind of start doing that more and more often, trying to get some kind of relief.
Yeah, I've certainly seen patients that have to have an esophageal stricture, which is what that condition is called, dilated on more than one occasion, although I would have to say every other year seems a bit frequent. And it kind of puzzles me still that he's having reflux symptoms every night. And I guess one thing I would say is if he's having nightly reflux symptoms and he's treated on a medication, I would say that probably the amount or type of medication might need to be increased, because really you don't want to be having reflux symptoms every night, and needing a dilation every couple of years to me means at least that treatment probably isn't quite adequate yet.
Well, the quality of life issues there are abundant, aren't they?
Absolutely. I think in this case, it's important for people to know that generally about 80 to 90% of people with reflux will respond to once daily medication. And if you don't, it's important to look for other causes, such as a stomach pumping problem, other reasons that need to be excluded, such as, like Dr. Walsh mentioned earlier, gastroparesis, where your stomach doesn't squeeze as well, and then you can potentially cancer. You know, I agree that having your esophagus stretched every 2 years seems a bit too frequent, and it raises what we talked about a little bit earlier about maybe this isn't acid reflux, but perhaps non-acid reflux, and so that needs to be excluded in this case.
Okay. Stanley is on the line now. Stanley, thanks for watching Doc's On Call. What's your question?
Okay, I have trouble. Usually it's when I'm sleeping. I'll have like acid come up and my throat swells shut. I have a real hard time breathing for like 30 seconds or so before I can, really get any air in and breathe again. And I take omeprazole, and it seems to control it pretty good, but I was wondering if you can take that indefinitely long term. I've heard that it makes your bones brittle.
Good question, Stanley.
Well, certainly people can take any proton pump inhibitor for extended periods of time, but as with any medication that you can take, there are always risks and benefits to those medications. And indeed, the proton pump inhibitors can cause a loss of bone density, and they do some of that through the decrease in the absorption of calcium. So you decrease the amount of acid in the stomach, and that acid is required to absorb calcium. And if you can't absorb the calcium, eventually you can lose some bone density. And one of the ways we fight that actually is to have our patients that are on proton pump inhibitors take calcium citrate as opposed to calcium carbonate. Calcium citrate is more easily absorbed in a low acid environment. Other things that you can have absorption problems with would be like vitamin B12. That can also be poorly absorbed if your stomach doesn't have enough acid. So they are safe over the long term, and certainly safer than the effects of chronic gastroesophageal reflux. However, once again, like any medicine, the shorter the duration you can use it and gain symptom relief, generally the better.
Sure. Well, and it sounds like he was well informed too, did a little bit of his homework, knows that there is that potential for some bone brittleness issues, and as you said, there you outweigh the good and the bad, and then you try to compensate with other good behaviors.
Right. No, it's a great question, and as with any medication, what is the risk of this medication, and does it outweigh the potential benefit, and vice versa? And if you do need to be on it for long-term relief, you can try to prevent some of those side effects by taking a calcium supplement.
All right. Do we have another caller, I believe? Debbie is on the line. Thanks for waiting. Thanks for your patience. What's on your mind?
Yes, hi. I have Barrett's esophagus, but it's already with dysplasia. So I'm wondering if the halo ablation therapy will work.
Good question, Debbie. Doctor?
It's a great question, and the AGA, the American Gastroenterology Association, released guidelines last March, so it's been about a year now, that formally recommends ablation in patients who have Barrett's esophagus with dysplasia. So I would encourage going to a specialist to see if you're in fact eligible for that, and we can get started on that.
And this would be for someone who has had this condition long term, has not found relief?
Right. I think it's important. She referred to the term dysplasia. Now,
Yes.
Barrett's esophagus is a step in the process to cancer. After Barrett's esophagus, you get dysplasia. So if there's dysplasia, you're already on the road to cancer.
Mm-hmm.
And so, not to say you'll get it, but you're taking that pipeline down.
Right.
So now we do have this new intervention that can go in and eliminate that Barrett's mucosa and the dysplasia contained within it.
And that would be much better than the alternative, as you described. Waiting for an inevitable cancer is
Correct.
is not a good thing. So,
Correct.
interesting developments in the world of medicine as always. Doctors, we so appreciate your presence here tonight, Dr. Kokar, Dr. Walsh, and Methodist Medical Center for sponsoring this evening's discussion. If we didn't get to your question, we'll try to put some information up online, perhaps on the Methodist site. And we'll be back again in a couple of weeks with another Docs on Call. Join us again then. Thanks for watching. Until then, I'm Gina Morse. Have a great night.